Okay, good afternoon. My name is Nina Ignaczak. I'm the founder of Planet Detroit, and we're excited to welcome you today to our webinar on community health workers in Michigan, how they're closing the care gap, and issues that they're facing with respect to cuts in Medicaid and just in general challenges with funding. Thank you so much for joining us today. A reminder, if you're watching online somewhere, you can always post your comments or your questions in the comments of the post that you're watching, whether it's on YouTube or Facebook or LinkedIn, and then you will be able to see those, and we can try to address them when we get to the questions. So we have a really amazing panel today. We have Kareem Beg, who is the CEO of MISHWA, Michigan Community Health Workers Alliance, Teresa Krell, a community health worker with Trinity Health, Jay Clement, who directs the community health worker program, among other things, at Henry Ford Health System in Detroit. And I know I got your title wrong, Jay, I'm sorry about that. But you'll have a chance to introduce yourself. We've got Richard Bryce with Chast Center in Southwest Detroit, a community health clinic. And we have Shannon Seymour, who is a Trinity Health patient and has worked with a community health worker and is somebody that we have featured in our work. So I'm going to just let everybody go around and chat and answer a bit of a question. But before I do that, I just wanted to make sure that everybody has access to our series on community health workers that we published in Planet Detroit. It was funded through with assistance from the Michigan Health Endowment Fund, and then also co-published with the Detroit Metro Times. So thank you to both of those organizations for their help with getting this off. So Shannon, I'm going to start with you. Sorry, Shannon also goes as Show. I'm going to start with you. You're a patient at Trinity Health, and your story was pretty compelling and really illustrated the impact of community health workers and the differences that they can make in patients' lives. Would you mind briefly sharing what was happening in your life when you first met community health worker Regina Gully, and how did that support make a difference?
Sure. And thank you for having me. At the time that I first met Regina, I was going through a lot. My health wasn't in the best place. I was feeling overwhelmed, trying to navigate appointments, paperwork, and just life in general. I couldn't keep up with a steady income due to frequent hospitalizations, and Regina stepped in. I was referred to a community health worker about her primary care, and I reached out to her, and she was able to help, but not just with medical things. She helped me feel like I wasn't alone. She listened to me, she connected with me. She was able to give me resources that I didn't even know existed. And she gave me the confidence to speak up for myself and to kind of take charge of my own care. And that support helped me from feeling stuck to feeling like I could take steps forward again, and that was extremely important and life-saving, really. If it weren't for her, I would have given up a long time ago.
Mm-hmm. Oh. Thank you so much for that story and for sharing your story with us.
Mm-hmm.
Next on our panel is Kareem Beg, who is the Executive Director of Michigan Community Health Workers Alliance. Kareem, you work with people like Regina and Show across the state. Community health workers are in a variety of healthcare settings. What do you see in terms of the gaps that they're filling that other professionals aren't able to in our current healthcare system?
Yeah, thank you for that, Nina, and good afternoon, everybody. Again, my name is Kareem Beg. I'm the Executive Director with the Michigan Community Health Worker Alliance, and really Show summarized it phenomenally. Community health workers, they're the bridge between Michigan families and individuals and the care that they deserve. Really, they close the gaps that no medical chart or insurance code can really fully capture. Like Show mentioned, like CHWs in Michigan, they're the first point of individuals, or the first point of trust for individuals in helping to navigate our healthcare and social services systems. Community health workers, they fill those critical gaps by addressing the whole person, as Sho had mentioned, not only their medical needs, but also what we call the social determinants of health. So items like housing, food access, transportation, and benefits navigation, amongst others, all of those that directly influence health outcomes. Because community health workers, they share that lived experience and that cultural understanding with the individuals and the communities that they serve, they're able to build those relationships and remove barriers that in other ways that professionals may not be able to. We see the impact of community health workers every day in the individuals that they serve, looking at improved health outcomes, reduced emergency room utilization, and really just stronger connections between people and the resources that keep them healthy. So, overall, community health workers, they're there to be that bridge. They're that trusted messenger, that individual that you turn to, when you need that support, you need that help, and you just need that listening ear to be there to help you just navigate, the complex health system.
Got it. Thank you. And I think we haven't actually defined it for the group. So for those who may not know, what in just one sentence or less, what is a community health worker?
Absolutely. So community health workers, they're commonly known as trusted members of the communities that they serve. And really, they serve to support bridging those cultural, those linguistic, and those systemic gaps between residents and the health and the social services systems. There are a number of core competencies that define the community health worker role. And within those, there are skills and sub-skills that community health workers leverage to support individuals on a daily basis in navigating the healthcare and the social care systems.
Thanks for that. Teresa, you are a community health worker at Trinity Health, and you lead the community health workers. Can you describe a typical day? There's probably no one typical day, but for the most part, what you're seeing day to day, and some of the biggest challenges your clients face, and then how you help them navigate.
Absolutely. Thank you for having me. Yes, I am part of the Trinity Health Social Care Community Health Worker team, and I lead the Southeastern Michigan. I'm based here in Pontiac. And one of the things I love about this job is that no day is the same. You'll see me a lot with patients, maybe in person, over the phone, helping them really figure out what their needs are and how to problem solve solutions for them. That may be applying for insurance, it may be recommending resources for food, utilities, you name it. There's a broad scope that we help with. You'll also see me perhaps with a wagon. Maybe I'm restocking a food pantry or our personal care items or clothing, or finding a cane that I'll find a home for a patient. I problem solve with the other community health workers on the team. Not every patient is the same, and we really have to collaborate with each other. I'll collaborate with other community organizations and the medical care team, whether it's the inpatient staff or outpatient staff. And I'm in a lot of meetings with our CHW team to really better grow the program, train, and see what else we can do to keep up with the times. And the patient needs. So the biggest challenges, when I think of the biggest challenges, I'm here in Pontiac, I will absolutely say food, access to care, and housing. Those are our biggest challenges that we see. You'll see those on our community health needs assessment aligning. So how would I help someone with food, housing, and access to care will depend on the patient. For food, I typically start with a SNAP application. So for those that don't know what SNAP is, you might know it as food stamps, bridge card, EBT, all the same. I'll help them apply for benefits, get the documents, and make sure they had that interview so they can obtain a bridge card, and then how to use it. I also here at Trinity Health Oakland have a lovely farm, and we have a farm share assistance program. So I'll try to enroll them in that so they can get produce weekly. And it's a great program because they can try something new that they might not have been able to obtain. I also recommend food pantries at our local CHW office. We have a little food pantry that they can shop and get items. And when I'm recommending a food pantry, I'm really recommending one that makes sense for the patient, where they live, what days they're not working and able to go to it. Do they need delivery? Really tailoring the food resources to make sure they make sense for that person. For access to care, I would help patients with insurance. We'll start with Medicaid coverage if they qualify. If not, maybe we're looking at marketplace insurance or a hospital assistance program because they need coverage so they can go to their doctors. It's also about transportation. Can they get to the doctor? Do they need help with Medicaid transportation or free or low cost transportation? Making sure they have a way to get to their appointment. And also helping them find a specialist. Sometimes it's tricky to find one in network and one that's going to work for you. And then remembering about that appointment. There's been times where I just wrote a calendar and I try to make it as simple as possible. Here's what time your ride is going to pick you up and take you home, in a calendar so we can really keep track. And I'm a huge MyChart fan, so I absolutely am guiding people on how to use MyChart so they'll make that appointment, so they'll see when their medications are renewed and all that. And for housing is tricky because housing for one person might not be the same for the next. With housing, we help if they have an eviction note, apply for state emergency relief on My Bridges. If that works out, that will hopefully help. Or we go to the next community resource agency. We also might help them with a shutoff notice or past due. Sometimes staying in the current housing situation makes sense, and that's keep you there. Other times it might not. I had a patient where they were not able to afford their rent. And long term, it didn't make sense for them to stay there since they lost their roommate. So for us, we really had to think maybe it's best that we find you a place that is a smaller apartment that you can afford long term. But even with that, we knew transportation was a barrier. So I needed to find a place that had a grocery store in walking distance and had her furniture. How do you get that moved? So working with local volunteers in our community to really make that housing need work for long term is what I would do. Thank you.
That is a lot.
Sorry for so much information.
No, that's so you really is. But what I heard you say, it's access to care, access to food, and access to housing, and then transportation is also an issue. Yeah. All right. Jay, I have your correct title here. I'm so sorry. Director of Community Health Programs and Strategies at Henry Ford Health, correct?
Actually, it's Vice President of Community Health Programs and Strategies, but
I'm so sorry. Vice President of Community Health Programs and Strategies. So Jay, Henry Ford has really kind of been a leader in this space. You have one of the oldest programs related to community health, and it's established and in the system. What has it taken and why did Henry Ford decide to lead on this issue and build one of Michigan's most developed community health worker programs?
Well, thank you for having me. And it really is an honor, and I feel like a big responsibility to be here to represent the work of so many people. But in answering your question of what it's taken, I thought immediately of one of our veteran CHWs, Mike Anderson, who always says that CHWs are flexible and adaptable. And it's taken all of our flexibility and adaptability to build this CHW hub model and infrastructure. We are fortunate, I think, at systems like Henry Ford, where we have always prioritized the health and well-being of the communities that we serve. And Henry Ford has also always been an innovative organization. So when the senior leader for our department, which is the Community Health, Education, and Wellness, and we call it CHW for short, but Dr. Kimberly Dawn Wisdom has been steeped in CHW work for decades, actually starting out in a REACH grant with CHAS. So shout out to Dr. Bryce there some years ago. And when she was exposed to community health worker model over 20 years ago and working with some people who we would consider trailblazers in this space now, like Gloria Palmisano and Edie Kiefer and others, they agreed 20 plus years ago that they wouldn't consider their careers done until CHWs were a sustained workforce. And it's taken that kind of relentless advocacy and leadership that really gave CHW, our department, a strong foundation to build the CHW hub model. Having that kind of physician leadership support I think was critical to the model for us, but we still had to provide proof of concept. So Dr. Wisdom did a lot of work over decades, including embedding CHWs to reduce infant mortality disparities in Detroit through our program Win Network. And that was exciting. And it got the attention of a lot of other people within the health system who wanted to try using community health workers in their settings. And the CHW department was elated to innovate in this way. So we wanted to be the home base for this work. We wanted to have a CHW hub standardized so that when people thought of the One Henry Ford experience, that all of our CHWs would have been recruited, trained, deployed, and evaluated in the same way across the enterprise. And we just built from our grant-funded demonstration of how this was working over years of seeing that grow in different ebbs and flow.
Got it. Thank you. And last but not least, Dr. Richard Bryce, family physician and chief medical officer at CHAS Center in Detroit. CHAS is also another obviously early innovator in community health workers, and probably before they even were called community health workers, had people working in this capacity. Tell us a little bit about CHAS and in the role that they play in the population, in the communities that you serve there.
Thanks so much, Nina. I appreciate the question. Definitely just want to give a shout out to everybody else. The work that's being done is really incredible. Definitely have a lot of love for Jay and all her amazing things as well. When it comes to CHAS, so as was said before, so CHAS has 2 locations right now. We have CHAS, our Southwest location, which is in Southwest Detroit, large immigrant population, definitely from Mexico, Central America, South America. And then we also have a partnership with the Pope Francis Center as well recently with the Neighborhood Service Organization, which do a lot of work with those experiencing homelessness as well. And so from our standpoint, fortunately, similar to what Jay had mentioned, CHAS alongside Dr. Wisdom from Henry Ford and some incredible people from University of Michigan kind of put this large CDC grant into creating support for CHWs at CHAS. And the idea was putting CHWs into the home of those patients that were experiencing diabetes and trying to give them the tools and understanding and learning to improve the outcomes of their health. And fortunately, we were able to find that in that incredible grant. That moved on to another large grant that we had called the FAM Act that was not only teaching the individuals experiencing diabetes, but their family members or support ones in the home to make sure that the care was being provided. And that was also really, really a positive experience for their patients and their families in terms of health outcomes related to diabetes as well. And so I think, CHAS has definitely seen these benefits. Very excited to see Kareem from Mishwa, incredible organization supporting CHW work, and the advocacy, especially to get reimbursement from the state, has been so incredible to allow this to be a more sustainable model. We are, one thing I can tell you, so I'm a primary care physician, and I'd love to say that the influence that I have on my patients is important. But in reality, if you look at some of the research, it's really like 20%. I see you now, I'll see you in 3-4 months from now. I hope that people will remember what I said 10 minutes after they leave the room. But in reality, we know that the other 80% is going to be focused more on those social determinants of health and all the other factors that have been brought up today. And that's really the benefit that we see with CHWs. Teresa made a great point of all the incredible things that she's doing for her patients. And I think that I know and I trust our incredible CHWs at CHAS to be able to meet those gaps for our patients, especially understanding many of the vulnerabilities that they have related to so many different social determinants. And so now I'm really proud to say of all these years of working with CHWs and being able to find unique funding streams utilizing Medicaid and some of the support from the state. We have close to 20 CHWs at CHAS that are doing a wide variety of things. We have multiple in our outreach and enrollment department, which are incredible to make sure people are getting insurance. Our doulas, actually, we have 6 doulas as well that are trained to be CHWs to make sure that we're also able to utilize some of the benefits of CHWs alongside helping somebody through their prenatal care time and their delivery time for having a baby. Our street medicine team as well has a CHW that can really try to help support those gaps that our patients have. And so at CHAS, we've just been super proud of the work of our CHWs. And I know myself as a primary care physician cannot have the incredible outcomes related to the health of our patients if it wasn't for the CHW support that we have.
Got it. Thank you for that. We're going to dive a little bit into the policy and sustainability issues faced by these CHW programs across the state. And we'll start with Kareem from Mishwa. Kareem, Medicaid reimbursement for CHWs began in January of 2024. And we know that with federal Medicaid cuts looming, some of that may be in question. How has the rollout gone? What have you seen in terms of since it's been released? And what are some of the changes or risks that you see as policy changements or Medicaid cuts loom here now with the new Trump administration?
Yeah, thank you for that. Really just, the Medicaid fee-for-service reimbursement rollout, with that just being a culmination of, just the years of work by so many trailblazers in the field that Jay, as well as Dr. Bryce mentioned as well. I mean, it's still in the early stages, even though January 2024, was a little over a year and a half ago. Still, as we're looking at this new policy and, at the organizational uptake, really it's, in its nascent stages. We've seen strong uptake, from our health system partners, such as, Henry Ford, as well as Trinity Health, as well as local health departments. But as we're looking at organizations, especially smaller community-based ones, where community health workers are also stationed, that there are challenges that continue to arise. So as we're looking at, specifically looking at just community health workers being able to navigate the state systems such as CHWs, which is where providers are able, to submit claims for reimbursement, organizational capacity to integrate like billing processes, and then overall just understanding, with a new policy, what are the service codes that, as Teresa had mentioned, there's so much that community health workers do. What are those allowable services that can be reimbursed for that community health workers deliver? Mm-hmm. Ultimately, all of that and the admin capacities to support these issues, are some of the main points that we're seeing come up to the top from our organizations. As we're looking at, this, I'm not going to call it the name that it's colloquially known as, but that bill, that has now been, yeah, that big one, and the Medicaid cuts that are contained within them, they're deeply concerning because over the years of work and investment that have gone into building up this, trained and really just, just evolving community health worker workforce. I mean, that puts to threat, the infrastructure that we're continuing to build upon. Mm-hmm. As we're moving forward, really, as we're looking to stabilize and continue to grow the workforce, at a state level and at a federal level, we need to protect that Medicaid funding. And then, looking specifically in Michigan, expand the scope of reimbursable CHW services. Just knowing that a lot of the work that community health workers do is that in between that 80% that, Dr. Bryce had mentioned, that involves, phone calls, connecting with patients, being able to drive out, visit them and meet them where they're at in the community, and to have that covered, have those services covered underneath the policy would be a big win as organizations are looking really at, the return on investment in implementing or leveraging this funding stream. We also want to continue to invest in CHW certification training, but then also the supervision as well too, knowing that, this workforce, and speaking as a community health worker myself, I mean, we're at high risk for burnout. So having, supportive, understanding supervisors who understand, that each day does look different and how to help support, their CHW team in managing, the ebbs and the flows, the client issues, and the emotional toll, as our community health workers are, pouring into their clients, how are they refilling their cup? Supporting that supervision structure that, helps to continue the sustainability of the workforce. And then finally, looking at living in sustainable wages for community health workers as well too. Right now with the current reimbursement rate, I mean, it is markedly low. So as we're looking at, the impact that has on organizations to be able to support, either a portion of, a community health workers role or that full role, we want to continue to support and advocate for a living and sustainable wage. With that living and sustainable wage, we're going to be able to continue to build that trust, keep that continuity with the relationships that are built, like between Sho and Regina, or Teresa and the clients that she serves, as opposed to having turnover and then that impacting, the clients who need that trusting relationship, from the community health workers to navigate and really just impact their health outcomes. So all in all, really, as we continue to move forward, we work closely with the state of Michigan, as well as with, just phenomenal partners across the state, looking with, health systems, community-based organizations, local health departments, to really just drive the point home that, all in all, under this umbrella of care, if we don't put community health workers at the forefront, like they put their clients and their needs, then we're at risk of losing this critical workforce that's central to achieving health equity in Michigan.
And just to go a little further, what are the consequences of losing this workforce, or having this workforce be further strained?
Oh, and I see Jay, same reaction, and Dr. Bryce as well too. Without Michigan having access to a trained and sustained CHW workforce, I mean, essentially we'd be unwinding decades of work that has gone into investing in this workforce, and really just, as we're looking at the various studies and, the return on investment that community health workers bring in terms of driving, improved health outcomes, reduced emergency room utilization, but then overall, as we're looking at overall health status of the most vulnerable individuals in Michigan and those communities that leverage community health worker services, I mean, the impact is tantamount. The metrics are out there. I've shared, some on MISHWA's website, but really just to think about it overall, that is a road that we want to really just deviate from and continue down the line of supporting our CHWs. So, just appreciative for, this panel, the work of everybody here, because it takes a village, and it takes our village to really just continue to elevate the impact and the value that community health workers bring to Michigan as well as nationally.
Got it. And we'll share that link out with attendees after the webinar and put it in the comments so people can see it. Jay, I know you've got to run a little bit early. From the perspective of Henry Ford, you haven't, as far as I know, from my reporting a couple months ago, still haven't made a lot of progress in terms of the Medicaid reimbursement. It's sort of something that you've been able to sustain in budgets or parts of budgets of different departments. What are some of those barriers to sustaining those CHWs long term within the Henry Ford Health System, and how do you address them?
Well, okay, that's a combo question, so I'm going to try to take both parts.
Yeah.
With the barriers, I think the easiest way I can describe it is being a small fish in a big pond or a lake or an ocean. So we're a 50,000 plus employee enterprise, and I have a couple dozen CHWs. So prioritizing, what the nurses need, what CHWs are asking for, it's a different kind of ballpark when it's a part of a large system, I think, and that's a nuance. That's one of the nuances. The other thing that I think about is that being in this space and starting it with grant funding, and I would describe CHW as a magical place because the work that we do and the work that Dr. Wisdom leads kind of makes it look easy. So there have been plenty of times where we've made appeals, and the response we get is just write another grant, because it seems like that's the easy button that you can press. And at the same time that we were demonstrating the great work through these grant funded programs, the funders were beginning to say, well, you've demonstrated this concept already. It's benefiting the health system. It's benefiting the payers. It's benefiting the government. They should pay for it. We don't want to continue to fund the community health workers. And it was critical, again, being the small team asking for access to electronic health records and being allowed to document there. That's going to give us the visibility that we need, but also the connective tissue to have relevance for providers to say, oh, this patient got assessed and their needs were met, and now I'm looking at their great outcomes. So having those kind of barriers, and one of the one of the silver linings of the pandemic was having those catalysts that would allow us to innovate and create rapid change. So in 2020, we did get our CHWs integrated into the electronic health record, which makes them more visible and allows us to correlate their data with value-based care objectives. And just really quickly, value-based care is about keeping people as healthy as possible for the best cost possible, moving away from the fee-for-service or the sick care kind of model. So we're able to show that relevance. Having the Medicaid reimbursement policy is a huge achievement. And again, like, shout out to all the trailblazers and to Mishwa, our government affairs team and health policy teams, MPCA, Michigan Primary Care. I'm not going to try to name all the people that got it over the finish line. It was a huge achievement. But that's where we were like, oh, it's not easy to just, where's the button? Press the button, flip the switch to turn this on. It takes a lot. And I don't think most people realize what it would take, especially because they did not come, the reimbursement does not come in a bundled payment or some other existing mechanism. It's not as easy as just, oh, here are the billing codes and let's use them. We had to meet with revenue cycle and analyze what this would yield for the system. Is this worth our wow? We had to put in requests with our IT team, our Helios team. There were so many different layers. And in even normal circumstances, this process of designing workflows, creating the builds that are needed, because even though we got community health workers into Epic, which our electronic health record, which was a huge win, they weren't set up for billing because there was no billing for CHWs back in 2020 when we did it. So things have to be rebuilt in IT. And I think in normal times, that could take anywhere from 6 to 9 months to occur. These are not normal times for a variety of reasons. Mm-hmm. And not the least of which is that Henry Ford just started a joint venture with Ascension Michigan Hospitals, which is a tremendous opportunity for us to expand our reach and to scale up this kind of work across a larger footprint in Michigan. But one of the essential parts of doing that is having all of those legacy Ascension hospitals be able to use our same electronic health record. Mm-hmm. So when we're talking about onboarding 30,000 people, wow, or so, and building this thing for 20-something people to use, it's considered a non-urgent priority. And even though people are still continuing to work towards it in the background, the pace of it, I think, is a lot slower than we had originally anticipated. But we are being flexible and adaptable and doing everything we can in the meantime and in between time to work around it and to be ready once we get the other priorities complete for our system, that we can go ahead. Somebody will flip that switch and make it a go.
Got it. So this may be one of the situations where it's a little bit easier to be a smaller entity. I wanted to hear from Dr. Bryce about how reimbursement has gone for an outfit like CHAS, which has maybe more community health workers per capita than Henry Ford, but maybe less access to the administrative resources.
Yeah, thanks, Ina. I think it kind of goes both ways. If you look at historically, if you go back to some of those other grants that I mentioned before, and even some other, we've had multiple grants that have always tried to incorporate CHWs into the work. The challenge that would occur is you would do the grant would be around for a couple of years. And then when the grant was done, what happened to those CHWs that you were employing? And unfortunately, as sad as it is to say, is that we had to let CHWs go. And that goes back to what Kareem was saying, like, you just train people, you have people that are connected in the community and they're making an impact. And that was obviously a big letdown. And so obviously the incredible work and advocacy to get some reimbursement from the state is great. Mm-hmm. I don't want to bite the hand that feeds us, but it's not a lot. It's not like this huge payment that's there. And so what we've still had to do is still incorporate grant funding to find unique positions And then on top of that, then use the reimbursements from the state. And those have obviously been helpful.
Mhm.
Obviously, similar to what Kareem had said, it's going to be a challenging time coming forward as the state has to make decisions based on Medicaid and how is that going to play a role with some of the most vulnerable of our patients. So that's a concern. One thing I would say is, fortunately at CHWs, we've been doing this for a long time, so we see the benefit. Dr. Valbuena, who is our CEO, has been a huge advocate for CHW work, and knowing that we need to incorporate CHWs, that's like in who we are. But, I think that's, for a place like CHWs, we've been able to make it work. And obviously we've had some really talented people do that. There's another group though, like if you're, I think for a larger hospital system like Henry Ford, which obviously work very close with, you can kind of take that, the ebbs and flows of other funding sources, and especially with Medicaid. But what about some of those smaller clinics that are just on their own, that haven't really been able to get into this? I think it's really hard to take that first step, knowing if you don't have grant funding or other revenue sources, can you make this sustainable just with what Medicaid is paying right now? And at this point, it's still a challenge. I know there's still advocacy going on at the state to continue to increase the reimbursement, but we are definitely in a difficult time right now. But once again, just so supportive of the incredible work of our CHWs. Couldn't do what we're doing without them. And I think more reimbursement should be coming their way, hopefully.
Got it. Okay. So to close out this section, I have a question for Kareem, Jay, and Dr. Bryce, but I'll let Jay go first because I know she's got to run. What would you like to see happen in the next, 3 to 5 years? Well, I guess we should say 2 to 3 years, as we get through this Trump 2 era and some of these changes happen. What would you like to see happen in terms of community health workers within your institution?
Well, I really want to appreciate that question, and also this platform. In case I do have to leave, this has been a very exciting conversation to be a part of. And I say that because my response to this is that having the series of articles, I think, is helping to shine the kind of light on this work that we really need. Because I will double down on Dr. Wisdom's vision for this, which actually makes my goosebumps pop out every time she says she wants to have 100 CHWs in 50 clinics in a year's time.
Yeah.
That is truly, operationalizing that kind of a vision would be tremendous for us. I think there are so many people that have a natural talent and gift and heart for this kind of work, and to be able to honor their time and their expertise with a career pathway that is solving care gaps, that is solving disparities in outcomes, that is solving efficiency needs for our healthcare systems, for our payer systems, and for other social service needs, would be like a dream come true. Mm-hmm. We know that there are workforce shortages in healthcare already, and it's expected that the problem will get worse before it gets better. And how do we innovate in a way that's going to create opportunities for the same communities that we're trying to serve, if that makes sense? This is a win-win to be able to employ and deploy people in the places that they live with the resources and support that they have connective tissue amongst. It drives down things like physician burnout. It increases patient satisfaction. There's so much more that we can do. I don't want to see CHWs in a box. I want to see them thrive and grow.
All right. Dr. Richard or Kareem, do you have anything to add?
Kareem, you want to go first, or you want me to go first? Cool. We're just kind of echoing exactly what Jay said. I think, one of the things that's so important, and, just hearing kind of from what Sho was saying before, I think Sho gets it when she is talking with her patients. and has that intimate connection. And I think that's so powerful. And unfortunately, I think our system is not set up to kind of support that. As we're talking about reimbursement rates, I mean, if I was looking to the future, I think continuing to advocate for more so that there would be more CHWs. I think that's the way that you make this more sustainable, especially as you continue to understand the benefits for those individuals. Because I really think when you're looking at medicine in general, of course, yeah, we reimburse well at the top when you're talking about the medical providers, but there are so many other people that have an influence in the health outcomes for patients. And so, I think that's really important. One last thing I'll give, and, I appreciate our insurance companies within our state, but many of our insurance companies have hired community health workers as somebody that like sits in an office and then calls patients. And I think they're trying to address those social determinants, but they're not necessarily from my community. They don't understand my patients. They understand that they're patients in their insurance panel. And I don't want to push away from that. Like, I think those are great positions, but in some ways I almost would argue I would prefer those insurance companies to say, hey, let me give you in your community access to connect to the people that would make the biggest impact for your patients in your community. And so these are just things to continue to think about because as I said, there are limitations in terms of what I do as a medical provider. And I see the gaps that the CHWs are able to meet that are so incredible. And so any ways to make sure that that is more sustainable is really what the hope is going forward.
Got it. Kareem, do you have anything else to add? Oh, did he go away? Or did I do that? Oh, I think he's not connected. I see his device is not connected. Hopefully he'll come back.
Can you hear me?
I can hear you.
Okay. I don't know what happened with the camera, so
Always something.
Yeah, at least we still got my voice, but really just want to echo, what Dr. Bryce and also what Jay said. Really, as we're looking at, the role and the impact of community health workers, and really just, one of the core tenets of being a community health worker is being able to be that bridge to the communities, in which you reside from. So, Dr. Price, like your point about, our insurance companies, being able to integrate and, support communities with, CHWs, really coming back, to the essence of community health worker work, embedding them in those communities. I mean, there have been initiatives, across the state that really, have been so innovative in the past couple of years that have led to the rapid expansion of the workforce. And with that rapid expansion, we want to ensure that, that training, that certification, and just that time investment, for these individuals, but then also for the communities and the funders is not for naught. To be able to, support our health system, support, local health departments, as well as community-based organizations in being able to hire more community health workers and sustain those positions, through braiding that funding. So looking at, how Dr. Bryce had mentioned, leveraging grant funding, but then also Medicaid reimbursement, and then also dollars from the state as well too, in various aspects, how all those come together to support and sustain the community health worker role, is something that MISHWA is going to continuously advocates for on a day-by-day basis. But I mean, we're going to continue and really just amplify this push as we move forward. And then additionally too, Jay had mentioned those career pathways, for community health workers. It's important, to be able to provide that pathway because, a community health worker, can serve at various levels, and we want to be able to help define those and create a trajectory like there is with social work, with nursing, with medicine, so on and so forth. So being able to really, display the benefits of becoming a community health worker and, what that role can advance into, while still ensuring that there's quality, in the service that they deliver, while uplifting those local needs, really is going to be tantamount, to our work moving forward from MISHWA. Ultimately, at the end of the day, our vision, and really just, from the trailblazers who set the foundation and really just, gave us, this platform really is just to ensure that at the end of the day, as we continue to move forward, Michigan, those vulnerable individuals, those communities, they all have access to a trained and sustained community health worker workforce.
Yeah, and I'm glad that you brought that up. We're gonna, in our last part of this, we're gonna go to the questions we got from the audience members that registered, and people are very interested in understanding what the pathways are as a profession. So we'll get more into that. But before we do that, we just want to spend a few more minutes with Sho and Teresa to learn about what it looks like day to day, and a little more information about, what this feels like on the ground. So Teresa, can you share a story that maybe captures the unique difference a community health worker can make, something beyond what a medical chart might show?
Of course. So actually for Trinity Health Community Health Worker Program, we are documenting in a medical chart, and we actually have been part of the medical chart for the last 5.5 years. And I'll tell you, that's been a game changer. Now, whether the patient's in the hospital or at their outpatient doctor or even on their My Chart, they can see that they're working with a community health worker, what goals they're working on, and what progress they've made. I remember recently I received a message from a provider's office the past month, and they messaged me about a patient where their A1C dropped from a 9 to a 6 within the 4 months that I was working with this patient. Remarkable improvement, remarkable. They could see that I had helped the patient get health insurance, got them connected to our farm, and helped them get to a monthly diabetes food pantry to help them manage their diabetes. But what they couldn't see is so much more about the relationship and the why that we made with that patient. Not everything we do is captured in the chart. Behind every success is the relationship building and the trust that the CHWs develop with the patient. Our goal is to ensure that patients feel respected and supported so we can truly make a meaningful impact on their lives. And you may not see that by looking at the chart, but that relationship building is something that really sets us apart.
Got it. And Sho, you talked a little bit about this in the beginning, but reflecting on what that support felt like with Regina, your community health worker, in terms of getting you through disability, getting you access to Medicaid, getting you help with eviction and utility challenges and all these things. What has that meant in terms of your path, and where are you today because of that assistance?
Yeah. So it felt like Regina was a godsend, really. Having her come in and provide me with certain support, it felt like somebody had thrown me a lifeline. Before she stepped in, I was juggling so many challenges. I felt like I was the headliner at the Ringling Brothers Circus or something. I had housing problems. I had health concerns, issues with Medicaid, having to call MDHHS. It was exhausting, even trying to keep my lights on at that point. It was exhausting. It was isolating. So Regina not only helped me navigate information that I didn't know about, she helped me navigate systems and paperwork. It was extremely frustrating at some points when I would get unnecessary pushback. So she would step in and be my voice, and make the phone calls and really know, what I was up against. And she could relate. She understood. She let me know that she had been in my shoes, where I kind of felt like no one else was really understanding, or they would just, kind of shrug my situation off. She didn't. She knew exactly, how I felt, what I was going through. And even if she couldn't help directly, or even if she didn't have the answer, she was just there, to be able to relate. She gave me hope. She helped me untangle so many things that we would be here forever if I went down a list of how important she is to me. One time she thought that her work with me was finished, like she was gonna, kind of not write me off, but say, oh, okay, well, we helped you with this and we're gonna close your file. And she was mistaken. We are tied in forever. I told her she's my new best friend. Like, it's funny, but she really is like a part of my family now. She really is my friend. having community health workers and having just somebody in your corner. I don't really know where I would be if it were not for her. Again, like I said, if she didn't have the answers, we would go look for them, or she would try to find them. And then if she couldn't, then she would just pray, with me. And that just speaks volumes about the character that you have to be in that type of position to, to be able to understand the frustrations that people are going through. She's really excellent. Whatever program, that needs to be looked at to make sure that we keep community health workers available, it's extremely important. I really don't know where I would be without her. She's given me stability, just support that changed my mindset from surviving to actually living and moving forward.
Thank you for that. And it was such a pleasure to be able to talk to both of you while reporting this story. Okay, we have some time for Q&A, and I'm glad Kareem was able to connect back, because he's probably one of the best people to answer these questions. But a lot of our audience questions were about kind of like, where do I sign up? How do I become a community health worker? And I guess it probably speaks to I think it was Jay who mentioned just, the amount of talent of people who are connected to their communities that are out there. But where would someone get started in terms of becoming a community health worker?
Absolutely. That is a great question from the audience, Nina. And I would say really how to become a community health worker. Essentially it starts with that lived experience, and that passion, to want to help and to serve and support. Now, following that as well, there are opportunities, to pursue formal certification as well too. So if you look at MISHWA, we have many training opportunities, to obtain that CHW certification, which is an 8-week, 166-hour course, and then additional micro-credential specializations. MISHWA offers scholarships to support individuals who may not be able to, bear the initial cost of certification, but then also looking at employers as well too. As you're looking and your heart is wanting to become a community health worker, please reach out to MISHWA as well too. One of the benefits of our membership is that, we continuously, receive job postings, updates, from our organizational members from CHWs, and want to continue to offer those as well too, as we're looking to bolster and sustain this workforce and support our partners to fill those positions as they come about. I'll tell you, even yesterday, I received an email that was now posted on our member portal that's calling for community health workers in the Wayne County area. So those job postings are available, and don't as you're reaching out, if you have any questions, please let us know. We can help guide you in the right direction, because community health workers, they go by a number of titles. So you may have a community health worker go by a community health worker, community care navigator, promotor de salud, so on and so forth. So not just limiting your search to a community health worker position. Depending on the organization, it may be listed, and it may be, the recruitment ad may be, tailored towards a different title, but essentially, encapsulates what it means to be a community health worker. So reach out to MISHWA if you have any questions, however we can guide you. And then we'll share some resources, to be able to, share out with, attendees as well, post on the website following the webinar.
Got it. And I'm posting a link to MISHWA's website into the comments now. And yes, we will definitely be sending those out. Anybody else have anything to add to that before I go on to the next question? Okay. Another question was, what are the qualifications? So you mentioned some certification, but is there some kind of base like schooling level or technical expertise or community experience that is typically required?
Yeah, that is another great question. So as we're looking at the qualifications to become a community health worker, and just taking it from the frame of CHW reimbursement with this Medicaid policy, the base qualification is to be able, an individual should have either a high school diploma or a GED and be 18 years or older. Following from that, community health workers, they come with a variety of lived experiences, whether through, working, volunteering, so on and so forth. But, if we're looking at those base qualifications, from a state level, again, just high school diploma or a GED, and being 18 years or older. And then from there, then that just opens up the door, for participation in, a CHW certification training like one that Mishwa offers.
Got it. And then anybody else have anything to add to that? Dr. Bryce, what do you typically look for when you're hiring community health workers?
Great call. Well, I can tell you, just looking at our awesome team, is that, I mentioned this before, there's kind of diverse roles that we have within even our CHW trained individuals. And so, I think there's obviously, and Kareem hinted at this, like the different trainings are fine to kind of get them set up, whether that's, and I'm sure Teresa can speak to that, of getting somebody insurance or housing or food or whatever. And so those are all important. But I think the one thing that's important for us is, like, can you connect to the community? That's really, really important for us. So, in our immigrant heavy population in Southwest Detroit, being able to speak Spanish and English, really, really important, right? For those that may be experiencing homelessness, if we can find somebody with lived experience, that's helpful, or somebody that actually has been connected or understands kind of the landscape dealing with housing, I think is really important. And so you're trying to do the best that you can to find somebody that can really connect to those people that represent that community, for sure.
Got it. Okay, probably the last question. Couple questions related to this we received, actually. There's interest in finding out, can community health workers do this work independently? Is there a pathway for that?
That is another great question, Nina. And I would say, as we look, at the evolving landscape of the community health worker field, there are opportunities for CHWs to work independently, to contract with organizations who may need support in terms of a CHW role as it pertains to, starting up a business or an LLC. We've seen, community health workers who've gone through and they've demonstrated the qualifications criteria to be able to deliver Medicaid reimbursable services. Now, with how the policy is currently written, there are some additional relationships that need to be established to allow those community health workers who want to set up like an independent consulting or a service firm to be able to bill successfully at this time. And that's another one of our advocacy points as well, too, as we're looking at really just the entrepreneurial nature, of our workforce as well, creating those opportunities, and having them embedded in policy to allow them to work independently, is going to be one of those areas we continue to support and uplift, in our conversations as well as in our advocacy moving forward.
All right. Great. Well, I just can't thank each of you enough for your time and your sharing your expertise and your experiences with us today. Anything else anybody wants to add before we sign off and let everybody get back to their day?
Yeah, I just want to from Mishwa's end and on behalf of, community health worker workforce, allies, funders, employers, really just want to thank you, Nina, Planet Detroit, as well as the Michigan Health Endowment Fund for, supporting this webinar, this platform for us to be able to share, but then also, being able to, really just encapsulate, just the role of community health workers, the impact that they have, on individuals on a daily basis. And, at the end of the day, that awareness, is something that, our community health worker workforce continuously needs. We all are advocates, as we, come together and support and uplift this vital workforce. So really so supportive, so appreciative of you. The Michigan Health Endowment Fund, Metro Times as well too, for affording us this platform, and just continued, opportunities to uplift and elevate, the phenomenal work that Teresa, that Regina do, and the impact that it has on individuals like Sho and others. So thank you so much.
Yes, I would also just love to thank you, Sho. Thank you for sharing your story. I know it's not easy to share, and we really appreciate it. And I appreciate Gina, and thank you, Planet Detroit, for having us.
Thank you.
No, thank you. Thank you so much for having me on. This was a joy. And like I said, anything that I can do to highlight Miss Regina, because she surely has been a joy.
She is a joy. I was sad she couldn't make it today, but it's great to have Teresa here in her stead. All right. Anything else before we shut down? Thank you so much, everybody. I hope you all have a great rest of your day. We will be sharing information back via email to everybody who registered. And if there's anything else we can do, just please reach out to us at planetdetroit.org for any other story ideas or things that we should be aware of in the future. Have a great rest of your day. Thank you so much.
Thank you, everybody. Take care.